Hello, hello, and welcome to today's episode of Talking All Things Cardiopulm. I am your host, Dr. Rachele Burriesci. Before we get into today's episode, I'd like to introduce our sponsor, Jane, a clinic management software and EMR with a human touch. Whether you're switching your software or going paperless for the first time, the Jane team knows that the onboarding process can feel a little bit overwhelming. That's why with Jane, you don't get a software, you get a whole team. Included in every Jane subscription is their award-winning customer support available by phone, email, and chat whenever you need it, and even on Saturdays. You can also book a free account, set up a consultation to review your account, and ensure you feel confident about going live. And if you'd like some extra advice along the way, you can tap into a lovely community of practitioners, clinic owners, and front desk staff through the Jane Community Facebook group. If you're interested in making the switch to Jane, head to jane.app/switch to book a one-on-one demo with a member of their support team. And don't forget to mention my code CardialPulm1MO at the time of sign up for a 1-month grace period on your new Jane account. Thanks again, Jane. All right, we are late in the week, and I wanted to talk about something that I feel so strongly about. I was going to do a podcast on this earlier in the week, or actually maybe it was after one of my hospital shifts, but I put a reel up about assessing vitals. I will live and die on this hill. We need to be assessing vitals with our patients. I can't tell you how many people I have seen over the course of the last even few months where if I was not assessing vitals, we would have had a big miss. So I had a patient who was a treat for the day. She actually wasn't a priority patient for, let's say, Saturday. She was a Saturday or Sunday, really had no plan for home in any of the notes, or like they were still working her up. She came in for chest pain. And I got a text early-ish morning saying that this patient was going home and needed PT clearance. So, not much really to report about in the prior PT note, in the sense that she wasn't able to do much. I think she walked 5 to 10 feet and then was dizzy. And when they assessed blood pressure, it was very low. So there really wasn't any intention of doing anything, nor did I see any notes about us, addressing that hypotension or orthostatic hypotension, whatever it may have been. So when I came into the room, the patient was sitting edge of bed and she was like, "I'm so glad you're here. I would love to go home. I'm feeling so much better today. I'm sitting here. I had some breakfast. I'm not dizzy at all. That's wonderful. I'm still going to assess vitals." So I'm glad I did. So, and I also texted the nurse before coming into the room, just like, "Hey, any heads up, any updates or concerns?" I didn't get an immediate answer, but I got it when I was ambulating with the patient. So, sitting edge of bed, her blood pressure looked great, 132/57 with a MAP of 73, heart rate was in the 80s. But her pulse ox was funky. 90, 88, 91. So I was like, huh, interesting. I didn't see anything in any note about pulse ox being low. I assessed vital trends prior to, because I knew she had hypotension. Nothing indicated that she would have low oxygen. Now, she did have on nail polish, so that can play a factor. And she was a Black female. So that actually can be a problem with pulse ox without the nail polish, being a factor. But with darker pigment, you actually get a false high SpO2. So I was like, this is interesting. Did some breathing just to kind of see if it would change. She had a tele monitor on, so I checked the tele heart rate to the pulse ox to make sure it was matched. It was, and it was showing good signal despite the nail polish. So I gave it some time. We did some breathing exercises and she got up to about 94%. Stood, reassessed. She had a drop to 118 over 57, which maintained the map at 73. So just to like pull this apart a little bit, it's not a drop in 20, right? So we have a drop in 14, which is just under orthostatic hypotension from sit to stand. You can't use the supine to stand numbers. So she is like right there. So I really didn't trust that she wasn't dizzy. In this, I shouldn't say trust. I was skeptical that she wasn't dizzy. So she reconfirmed that she wasn't dizzy. And we got about 10 feet in and she's like, but I'm a little woozy. So I was already a little bit more cautious. I had already pulled a chair to the door prior to seeing her because that's about as far as she made it yesterday. So I had a transport chair waiting for me at the door. She said she was fine. So we went a little bit more. At this time, I hear my phone go off. So we walked probably another 30 feet. I kept the blood pressure cuff on her and then asked her how she felt again. She's like, no, I feel pretty good. I can keep going. I was like, you know what? I would like to stop and just make sure we're good. So I made her sit, reassessed her blood pressure and her SpO2. Blood pressure stayed flat, 117 over 53 with a MAP of 65. So diastolic did drop, which made her MAP drop. But her pulse ox was 86%. So I check my phone and my phone says, oh, we've been monitoring her sats a bit. She's been running low. So nurse actually runs into me while we're sitting in the hallway. We're doing active deep breathing. I'm checking different ways to hold the pulse ox to see if I could beat the system on her nails. I did the sideways technique. I did the upside down technique. The sideways technique gave me the best signal, but I wasn't trusting it. When I had the heart rate match, she was like 89. So she was just under. It did go up with oxygen. It recovered to about like 93%. And we were just sitting there. She wasn't short of breath, anything like that. So I was talking with the nursing staff and I was talking with the patient if she was willing to remove some of the nail polish to see if we can get a true read, because now you have a couple of issues here. If it's a false low because of the nail polish and I give her oxygen, we might be over oxygenating her and she doesn't need it. If we don't know for sure and we're going to say, oh, it's fine, it's just the nail polish, and she is hypoxemic, well, we're just going to keep causing that reserve to be a problem. So we discussed different options. On the floor, they don't always have the forehead pulse ox. So I was asking the nurses if they had anything available. The patient actually really didn't want to take her nail polish off. She was talking about how it was like a part of her. And so we were having a discussion that it's, totally fine that she has nail polish on and all the things, but we could maybe remove one just to make sure she was safe. So we had agreed on removing one, but they were looking for a different, I want to say meter, but that's not the right word, a different attachment for the pulse ox. So she recovered. We were in the 90s again. And so now here's the thing. When you're being asked to clear a patient, right? This has a lot of nuance to it. Don't love those words. Some people take a lot of offense to clear, needs to clear PT. I don't take offense to it. But if I feel the patient isn't safe, then I hope that they respect that piece. So I had asked the nurse while we were in the hallway, I was like, did they do anything for her hypotension? Like, did she get any fluids? Did she receive a blood transfer? Like, I didn't see anything did they pull and adjust any meds? From my understanding, they didn't do anything after the hypotensive episode the day before. And there wasn't much talk about the oxygen being low. even though they were watching it. So I had to make a decision. She had 3 steps to get into her house. I could do it with the oxygen or not do it with the oxygen. So I chose to not do it with the oxygen after she had recovered to see what her response would be, because there was still a question whether or not it was true or not. So we did 3 step ups on a platform because I didn't have the 3-step training stair in this unit. And after we did the 3 steps, she was short of breath and dizzy. Reassessed, her blood pressure had dropped to 93/56 with a MAP of 65. Her heart rate was 111, so it had increased significantly, and her pulse ox again dropped to 86%. So it didn't seem to be inaccurate. It wasn't just a nail polish problem. So I gave that handoff. She's still dropping her pressures. And if you look across the trend, she started at 132/57 and ended at 93/56. So no matter which way you want to spin it, it's not just orthostatic hypotension, it's a hypotensive response to exercise. So the question is then, if you send this person home, even though she was relatively steady, she had assisted home from her daughter, which would be really the only reason why this could, in theory, work outside of the vital sign response. She wouldn't be safe, or she would end up right back in the emergency room. So this is where, if you're not assessing, you don't know. So when I made her sit, she wasn't symptomatic, but her sats were dropping. So then how far would she have gone in her own home before she couldn't go anymore, right? Like, she was describing some level of symptom, but she couldn't place it. She was calling it woozy. She's having a hypotensive response with stairs. She has to do stairs to get into her home. So even though it's only 3 steps to get in, she still has to do those 3 steps. And likely then she's got to walk from the car to those steps, right? Which would have been basically the equivalent of what we had just done. So then what, right? I had another episode, and I don't have those numbers in front of me right now, but I had a patient who was status post TAVR. It was supposed to be just like an in and out, quick screen. She was an older woman, moving well. She already walked a lap with cardiac rehab before I had gotten there. So let's say she walked with cardiac rehab at 7 or 8 in the morning, and I was there at like 10. And the nurse was like, "She's fine. She already walked a lap. She's great. She's going home. She's dressed." And I said, "Okay." And I just wanted to check in. She was older. I think she was like 87. And I walked in the room with the Dynamap, put the blood pressure cuff on, pulse ox on, just was chatting. And she was sitting in the like high 80s, 87%. She had a history of ILD. She did not wear oxygen at rest, but she did wear it at night. And so I'm texting the nurse as I'm like assessing her, because this was the first time she was off oxygen. When she walked with cardiac rehab in the morning, she was still on oxygen. And the vitals indicated that she did not have desaturation. We walked with the pulse ox on, and she was dropping into the 70s and was short of breath, like actively short of breath. She really wanted to go home. She was, kind of upset that we were kind of holding back on her, but she lived alone. She did not have, she was not wearing oxygen previously. She had oxygen in the home, but she was only wearing it at night. So she didn't have portability of said oxygen. But it's only because we were assessing that it even came to light. So I'm going to live and die on this hill. If you don't assess, you don't know. You have to be assessing your patients pre, during, and post. It takes extra time, period. It takes extra time. I'm telling you for fact, if you assess vitals, it's going to take you more time. but it's worth it because it gives you so much valuable information and valuable information to keep your patient safe. One of the big things that I teach about vital signs is if you take a blood pressure, a heart rate, an SpO2 in the moment that your patient isn't feeling well, that number doesn't mean a ton. Now, I will say oxygen is a little bit different because if, like the first lady I was talking about, if I would have assessed her oxygen and it was 86%, it tells me that she said 86%, but I still don't know where she started. So really important for you to be assessing before. You need a baseline number so the next number means something. So important with blood pressure and heart rate. I can't tell you how many people I have seen or have had questions relayed to me, and it usually goes something like this. Patient was really dizzy, so I assessed her blood pressure and it was this number. That number doesn't mean a ton, right? So a couple of ways you can look at this. The person was dizzy. Let's talk about my first lady. The person was dizzy and I assessed it and it was 118/57. But I don't have a starting number. That number is okay. That number's fine. Her map is fine. It's not a hypotensive number, but it makes a big difference that her blood pressure was 132/57 to start. If your person's blood pressure is, let's just say 90/50, just for example purpose, when they're dizzy and they're actively standing, you may say, oh, she's hypotensive. You might get a little bit more nervous. You might sit down and rest and wait. But what if you don't have a baseline number? What if her baseline number was 95/50? That would not be a concern. What if their blood pressure had been trending in the 90s/50s? Then it would not be a concern. If their blood pressure was 130/60 before you stood or before the patient was dizzy, yeah, that number is a problem. The point is, if you don't have a baseline value to compare it to, the number that you get when the person is symptomatic means a lot less. So, if you have the opportunity, and I understand that it's not always possible because I can tell you that I have wasted many a minutes looking for a Dynamap. Not every room has it. Not every floor has multiple. You might be competing with, the vitals check that's occurring at whatever time it is. Sometimes you have to make the judgment call to go without. You just hope that that's not the time that the episode happens. If you have the opportunity to assess vitals, you have the appropriate equipment, assess vitals, blood pressure, heart rate, SpO2 at minimum. Respiratory rate, I like to throw in, but it's not one that I do every single time. Be completely transparent with you. If you don't have a baseline value, you do not know. If you're not assessing, you don't know. The number doesn't hold as much weight unless you have trends or a baseline number to where you started. Position matters. Activity matters. What you're doing when you take that number matters. I can't tell you how many times I start my session with taking a vital and I'm like, hey, this is not the normal trend. Go and tell someone. And I'm like, what were you doing? I was like, I literally walked in and this was the number. So could you imagine if I didn't assess, right? Patients not always symptomatic. They don't have to be. Can it still be a concern? Yes. Are there times where those numbers are low, the patient is asymptomatic, and I keep going? Yes. But I have the data to help make those clinical decisions. This is how you build that crystal ball. This is how you anticipate what's going to happen. assessing, getting your data, being very vigilant about it. So I know that I take more time in my session because I'm going to take vitals, period. I am. I am going to live and die on this damn hill, and I am going to keep preaching from the rooftop to assess vitals with your patients, period. No matter what setting. You're in home health, assess vitals. You're in SNF, assess vitals. You're in acute care, you're in the ICU, you're virtual. You're an outpatient, assess vitals. If you're doing anything with an exercise prescription, assessing vitals is important. If you're doing anything with a patient who has comorbidities, vital signs is important. If you're working with a patient that has heart and lungs and you're doing anything in the realm of exercise, vital signs are important. Even if they're normal, they're valuable. Exercise prescription based on target heart rate is an important progression. Exercise prescription based on blood pressure response can be very valuable. Maybe patients are progressing too quick, but you're not assessing vitals and you're like, maybe the patient's more fatigued or they're more short of breath or they're really down for a few days after exercise. Vital signs. It can tell you so much. And it could also give you the green light, right? Like blood pressure is responding appropriately, heart rate's responding appropriately, SpO2 is responding appropriately. Green light, go. If they're not, then there's questions that can be asked. So, final answer, assess those vitals. It can be very important to help progress the patient. It can be very helpful to stay safe. It can be very helpful to give you confidence in making the next decision. And also, if something goes wrong, you have the data. Or if you're backing off because those numbers are so out of control that you're like, I can't push this person, you have those numbers. You have the data to say they're not responding to this. What else can we do? Be a part of that conversation. That's super important, right? Whether their heart rate is inappropriately increasing, whether their heart rate or blood pressure is dropping. That is a contraindication to exercise. Dropping blood pressure, dropping heart rate. If your intensity is increasing and your blood pressure, heart rate are dropping, your patient is not able to tolerate that activity. Period. And if that activity is functional mobility, then we definitely need to be having a conversation with our team. You are part of the conversation. Allow yourself to be part of the conversation. It starts with taking vitals. All right. That is all I have for you today. I hope you all have a wonderful night. Take those vitals and whatever you have to do, get after it.